Hello and welcome to another podcast. Today we're going to have a closer look at your bradyarrhythmias. Now bradyarrhythmias, again, you can have bradycardia, sinus bradycardia, and it's no problem. So there's no adverse effects. Our baseline treatment always stays the same. Always stays the same. We always investigate. We always make sure we have all our observations down, have IV access, bloods away if we can, ISAT if you have it within you. Look for causes of why you could have this bradycardia happening. If it's trauma related, so head injuries, spinal injuries, that sort of thing, then obviously those treatments have to be considered as well. Okay, so again, we look at those adverse effects. The adverse effects are the same as the tachyarrhythmias. Okay, so we're looking for signs of lack of perfusion. So does it affect blood pressure? Does it affect GCS? Is there evidence of chest pain or history of heart failure? If there is, we'll go down the is pathway first because that's the best way. Then we do what we've always done. Okay, it's been in our protocols, no problems at all, and we give our atropine. No worries. Atropine 500 to 600 realistically micrograms IV. Easy done. Then we decide, is it satisfactory? If it is, that's fantastic. We have to give one dose, then we go over to the other side. Okay? But if it's not, then we start moving down into other considerations. Now these considerations can be quite simple, then also you can get a little bit more complicated, and depending on what the patient has gone through will determine what sort of medication regime they move into. The first point of call is you can just consider giving more atropine. All the way up to 3 milligrams of atropine can be given over time before you would, well, you don't have to, you can give less, but before you definitively say that this is atropine resistant bradycardia. So up to 3 milligrams can be given of atropine, and atropine is considered the first line drug for bradycardias. If that doesn't work, then you can look at transcutaneous pacing. Now again, with pacing, I'll give you the generalization. The MRX can do it, very simple again, but needs to be practiced. Needs to be done with sedation as well. Okay, so again, not dry. You're delivering electricity into the heart, so it needs to be done with sedation on board. Now, generally, the range of pacing has a success range of around 50 to 100 milliamps. Okay, generally speaking. Once you get what's known as capture, now if you don't know what that means, then I suggest you do a lot more reading and practice it with your team. But once you get capture, then you are to increase the amount by 10% or 10 amps depending on your machine. So sub machines can go up by 2 milliamps, other machines are stuck with 5, so 10 milliamps. It increases each time. Okay, so depending on your machine, you can either go 10% or 10 milliamps above capture in order to maintain it. So when we looked right back at the first lesson, looking at the conduction pathway, where I talked about that threshold for your action potential, it's an all or nothing system. All we need to establish is the minimal amount of amps required to kick in that action potential, and then leave it at that. Okay, because even if you crank it up to 3 times the amount, it's not going to do any benefit. Okay, because action potential is all or nothing. You're going to have the same response, just cause more pain. Minimal amounts, move up, and then increase it by 10%. The rate that you should go at is essentially a range between 60 to 90, and that depends on the person's physiology. So if they're sitting at 40 and they don't have it, and they have a slight adverse effects, but they're still semi-conscious, you're not going to kick it straight up to 90, okay? Because that is a lot more. So you'll start small rate increase, and then once you've got pacing, you'll check the patient. If their blood pressure is still low, they've still got signs of lack of perfusion, then you obviously increase the rate. There's no point increasing the milliamps, like I said, all or nothing. It's not going to do anything, so you increase the rate from there. You need to monitor all the time when moving this patient because you can lose pacing. If you lose pacing do your troubleshooting, start at the patient, make sure everything is fine from the patient all the way back to the machine, and then fix the problem. If pacing isn't available, or you don't consider it's the way to go for this particular patient, then alternate medications can be given. Written on your screen, it says isoprenoline is an alternate drug that can be given. Now, in Australia, isoprenoline is considered one of the alternate drugs. Okay, so it's slightly different. So isoprenoline is not frontline drug, but it's given because it has your beta-1 agonist, your chronotropic and your inotropic, and also what's known as your dromatotropic effects when used. Okay, so it's similar to adrenaline, but it doesn't have any of your beta-2 or your alpha effects. So when we say beta-1, obviously the main focus of beta-1 is your chronotropic. Then you also have an off-cut of slight, minimal inotropic, and then dromatotropic effects, which is the main reason it's considered alternative. So if you're not following, dromatotropic effects is essentially effects on the conduction speeds within the AV node. Isoprenoline works directly on the AV node conduction speeds, okay, by stimulating the beta-1 and obviously the AV node itself. Okay, so that's your isoprenoline. Now, don't expect you, this is mostly for interest rates. Okay, other drugs that can be used for bradyarrhythmias is your adrenaline infusions. Okay, this time we're giving 2 to 10 micrograms per minute, depending on the patient's size and what sort of effects you want. Okay, lower doses you'll get just alpha effects. Slightly higher doses, it's not as absolute as one of the other drugs that we'll talk about, but it does have the extra effects, the higher doses you get, which is your beta-2 and your beta-1s infusions. But obviously that's going to increase preload, increase blood pressure, increase stroke volume, increase heart rate. So overall cardiac output is going to be improved by using adrenaline. Now, other drugs that can be considered. Okay, now if I pronounce these wrong, then sue me. But aminophylline is an alternate drug. Okay, now this is often given when you have atropine-resistant bradycardia. It works mostly on your sympathadrenal reflexes. Okay, so it wants to encourage sympathetic nervous system to actually be activated. Okay, much like your adrenaline. This drug is often used when you're dealing with neurogenic shock symptoms. So spinal cord injuries, the pathway to talk to spinal nerves to increase that has been cut off by the brain. So we want to give a drug to take over that pathway. Okay, because there's a severed connection. Now, dopamine is the other one. Again, it's often used when you have resistance to atropine. Now, dopamine and adrenaline are very, very similar. Okay, the main reason dopamine can be used is you don't get those beta-2 effects, and you can more easily, as compared to adrenaline, more easily tailor the dose to have a response. So if you have up to 5 micrograms per kilo per minute, then essentially the effects you'll get is vasodilated renal and coronary arteries. So that's a bonus. If you go from 5 to 10, then you get your beta-1 effects, similar to your isoprenoline that was given. If you go between 10 and 20, then you get your obviously beta, but then you also get your alpha effects as well. Okay, so that's why dopamine's still in the mix. There's a lot of literature out there that compares dopamine and adrenaline. Okay, so it's much of enough. It comes down to personal preference a lot of the time with those two. Okay, glucagon, you may be reading and thinking, well, that's unusual. Why would we give glucagon? The reason glucagon is given is pretty much a similar reason that it's used in anaphylaxis. So if you have bradycardia that's caused by beta blockers or calcium channel blockers, then essentially you're not going to be able to touch the heart rate itself. Okay, it's very difficult to get anything that will increase cardiac rate. So you want to have alternative effects. You want to have the effects on the catecholamine system, which is what glucagon does. So by giving glucagon, you'll activate the catecholamine system, which will increase preload, okay, by causing vasoconstriction. Okay, it's an alternate choice, basically, is what can be given, but that's why it's there. And your last one, glycopyrrolate, that's essentially used instead of atropine. So it's not used if atropine fails, but it's used instead of atropine. And as far as my knowledge extends, okay, it's mostly given pre-surgery. Okay, so if you're going to give anesthetics that can cause bradycardia, it's given before that. Okay, what it does is it corrects your parasympathetic imbalances. Okay, so it's often used normally for peptic ulcers and increased saliva production in children. Okay, but in this case for bradycardia, it's given more as a prophylactic for bradycardia. There's your myriad of drugs of what can be given. If all of those or some of those or whatever regime doesn't work, then you need to arrange for pacing. Okay, transvenous pacing, which is obviously the end result of what you will need if you're always going to be in bradycardia. Okay, you get a pacer put in. And in the event that we get a satisfactory response at any stage, so obviously it doesn't say it on the algorithm, but if you get the response you want, then you can back up. We always consider the probability of this bradycardia becoming asystole. So if it's sinus bradycardia, then we're looking pretty good. The only thing we need to consider is if we've had recent asystole. If we have, we need to consider, do we use pacing, do we use stabilizing drugs, that sort of thing. If the rhythm comes back and it's Mosbit's 2 or a 3 block, or you have something known as ventricular pausing for 3 seconds or more, then again, we need to start looking at pacing, we need to start looking at stabilizing. If all these things have worked and there's no risk of asystole that we have seen, then obviously we just continue monitoring the person until they either stay in bradycardia happily or the cause is fixed over time. So that's your bradycardic arrhythmias. Lots and lots and lots to consider, lots to talk about, and hopefully a hell of a lot for you guys to take away and practice. There's not much point me staying here talking this and expecting that you're going to be all over it. From here, we need to practice. Okay, and you need to get in your team. You need to have a better understanding of how to deal with arrhythmias, deal with cardiac problems correctly, and start looking at traumatic. If you have any questions associated with this podcast, then ask me. If you have any questions, start a discussion. Okay, until next time, take care.